Good afternoon. First, I'd like to welcome you all to our event today. It's our pleasure having you all in our meeting. My name is Mohammed Al-Maddah. I'm from Merck, digital lead for the Gulf countries within Merck. Today, our topic is managing hypothyroidism from diagnosis to personalized treatment plans. As you all know, hypothyroidism is a disease that is usually misdiagnosed, or it can be easily confused with other conditions. And the patient may suffer from these signs and symptoms of hypothyroidism for a long period of time without being noticed. Today, our speaker will take us through a patient journey, starting from diagnosis, how to diagnose, till the patient gets the right and the correct treatment. Without further delay, I would like to introduce Dr. Ghaida Qaddaha. Dr. Ghaida, she's a consultant endocrinologist, diabetologist in mid-care women and health, women and children in Dubai. Dr. Ghaida, she has worked in various prestigious hospitals across UAE as a consultant endo and diabetologist. Her expertise spans conditions related to diabetes, hypertension, dyslipidemia, and thyroid, of course. So welcome, Dr. Ghaida, and we are ready for your presentation.
Thank you, Mohammed, for the kind introduction. Good afternoon, ladies and gentlemen. It's a real pleasure and a privilege to be with you this afternoon to shed some light on the management of an extremely common clinical scenario that you will see in your clinical practice, especially at the level of primary care, and that is hypothyroidism. These are my disclosures, and what I would like to do in the coming half an hour or so is to touch briefly on the prevalence of hypothyroidism. Then I'll be discussing how do we classify the condition, what are its clinical features, how do we diagnose it, what are the associated health-related risks, and then focus my talk mainly on the management of hypothyroidism, and I will conclude by sharing with you some of the guideline recommendations. So, thyroid function is under control of the hypothalamic pituitary thyroid axis, where the hypothalamic TRH stimulates TSH secretion, which in turn stimulates the thyroid to make T4 and to a lesser extent T3. Hypothyroidism is defined as inability of the thyroid to make enough of the thyroid hormones. It's a very prevalent condition, and overt hypothyroidism is estimated to be present in about 0.1 to 2% of the general population. However, the less severe condition of subclinical hypothyroidism is much more common, and the prevalence is of the order of around 4 to 10% in the general population. Hypothyroidism is mainly a disease of women. It's about 5 to 8 times more common in women, and tends to increase in prevalence as we age. So it is estimated that in women above the age of 60, about 20% of them have hypothyroidism. As shown in this slide, which looks at the prevalence of hypothyroidism across all age groups from 18 up to more than 74 in both genders. So female are represented in blue and male are in pink. You'd think that the color coding should have been the other way around. Nevertheless, you can see that as we age, the prevalence of hypothyroidism increases. But at any given age, women in the blue bars have a lot more hypothyroidism than men. Hypothyroidism is classified in different ways. You can classify it by its onset of action, the onset of the disease, I mean. So it's either congenital, occurring at birth, or it's acquired, occurring later in life. By the severity of the condition, as either overt clinical hypothyroidism or the milder form of subclinical hypothyroidism, or by the etiology into either primary hypothyroidism, where the disease is within the thyroid, or secondary, where the disease is higher up at the level of the hypothalamus or the pituitary. Now, I think when we speak of hypothyroidism, most of the time we really mean primary hypothyroidism, as secondary hypothyroidism is not that common. It's pretty rare. So primary hypothyroidism, the commonest cause in our region and also in the US is probably autoimmune disease or Hashimoto's thyroiditis. However, worldwide, it's estimated that iodine deficiency is by far the most common cause of hypothyroidism. Damage to the thyroid, either by previous surgery or radiation to the neck, can cause hypothyroidism, and certain medications like amiodarone, lithium, tyrosine kinase inhibitors, etc., can also affect thyroid function. Secondary hypothyroidism, as I mentioned, is really quite uncommon, and it's due to diseases in the hypothalamic pituitary region, and this could be due to tumors, trauma, various forms of infection, infiltrative diseases, chronic lymphocytic hypophysitis, and certain drugs, especially those used in an ICU setting like dopamine and glucocorticoids, can affect hypothalamic pituitary function, leading to central hypothyroidism. By its severity, it's either overt clinical hypothyroidism, where the TSH is elevated, usually above 10, but this occurs in combination with a low free T4. The much commoner condition of subclinical hypothyroidism is characterized by a serum TSH that is above the upper limit of the reference range, but associated with normal free T4. So as illustrated in this slide, when the patient is euthyroid, all the three parameters of thyroid function, the TSH, the T3, and the T4 are well within the normal range. As subclinical hypothyroidism sets in, TSH being a very sensitive marker of any changes in thyroid functions, as the thyroid functions, the T3 and the T4 decline, and they are still within the normal range, the TSH, as you can see, is already above the upper limit of the reference range. And this progresses then to overt clinical hypothyroidism, where the TSH is elevated, accompanied by a reduction of circulating levels of both free T4 and free T3. The symptoms of hypothyroidism, as Mohammed mentioned, are extremely non-specific. And by far, the commonest symptoms that bring patients, especially women, to the healthcare provider is weakness, fatigue, hair loss, weight gain. But then hypothyroidism can be associated with mental sluggishness, depressed mood, voice changes, constipation, dry skin, menstrual irregularities, and cold intolerance. On examination, your patient may or may not have a goiter. They may be bradycardic. They may have diastolic hypertension, but perhaps the most classical sign of hypothyroidism when it occurs is a delayed relaxation of the delay in the relaxation phase of the deep tendon reflexes. Metabolically, these patients may have hyperlipidemia, especially elevated LDL cholesterol, macrocytic anemia. They may have elevated CPK and hyponatremia. How do we diagnose it? The diagnosis is very simple. TSH is by far the most sensitive indicator of primary hypothyroidism. All you have to do is to check the TSH, and depending on the lab you're dealing with, the range, the TSH level ranges between 0.4 to around 4 microns per liter. You may want to do also the T4 if the TSH is elevated to determine if your patient is in clinical overt hypothyroidism or in subclinical stage of hypothyroidism. Thyroid antibodies, especially the ATPO antibody, is associated with immune thyroiditis, Hashimoto's thyroiditis. Sometimes doing an ultrasound is helpful, and it demonstrates this typical hypoechoic heterogeneous echo pattern of Hashimoto's thyroiditis, and you can contrast that to the homogeneous echogenicity of a normal thyroid. I want to focus this part of the talk on subclinical hypothyroidism, because honestly, the diagnosis and the management of clinical overt hypothyroidism is pretty straightforward. Any patient with elevated TSH and low T4 and who you deem has overt clinical hypothyroidism should be on levothyroxine. Subclinical hypothyroidism is an entity that is surrounded by some ambiguities and uncertainties. Now, the question that we really need to ask is this clinical entity of subclinical hypothyroidism significant? Does it have any associated health-related risk? And the first risk is this: patients with subclinical hypothyroidism are at risk of progressing to overt hypothyroidism. It is estimated that on the average, about 2 to 4% of patients with subclinical hypothyroidism will convert annually to overt clinical hypothyroidism. And the risk of progression really depends on the baseline TSH. So the higher the baseline TSH, the more likely the patient will develop clinical hypothyroidism. Patients with positive thyroid antibodies are more likely also to progress than thyroid antibody negative patients. The other associated health-related risk of subclinical hypothyroidism is the association with dyslipidemia. So patients with subclinical hypothyroidism can have elevated LDL cholesterol, and the elevation in LDL cholesterol is really related to a reduction in both the number and the activity of the LDL receptors on the surface of hepatocytes, therefore interfering with the clearance of LDL particles from the circulation. As the LDL particles stay longer in the circulation, they tend to undergo oxidation and become more atherogenic. Another lipid abnormality is elevated triglycerides, and this is also due to increased production of triglyceride-rich particles by both the intestine, the chylomicrons, and the liver, like the VLDL, and also a reduction in clearance of triglyceride-rich particles from the circulation as a result of reduction in the activity of the enzyme, that is lipoprotein lipase, which is responsible for the clearance of these triglyceride-rich particles from the circulation. Good to know that the dyslipidemia of hypothyroidism is reversible with the treatment. This is a clinical study that looked at the effect of treatment on LDL cholesterol, and it divided patients by their baseline TSH into those with a TSH less than 12 and those with TSH above 12, and by their baseline LDL into a group with LDL at baseline of less than 4 millimole per liter and those with an LDL of more than 4 millimole per liter. And as you can see, treatment of any category, when you treat patients with thyroxine, the LDL cholesterol improves, it decreases. So the dyslipidemia of hypothyroidism is reversible with treatment. So hypothyroidism, even at the subclinical stage, is associated with dyslipidemia. And as I've mentioned, it also may be associated with diastolic hypertension, both at the end of the day, leading to atherosclerosis. Therefore, all the guidelines really recommend that in any newly diagnosed patient with dyslipidemia, that you check their TSH before starting them on lipid-lowering therapy, because you may improve the lipid profile without them requiring any lipid-lowering therapy. Is there an association between subclinical hypothyroidism and coronary heart disease? This is a meta-analysis of 7 prospective cohort studies, which showed that there's a significant trend for increased risk of coronary heart disease events in patients, that is to say, increased risk of non-fatal MI, coronary death, hospitalization for angina, and coronary revascularization. We're talking about an odds and hazard ratio of about 1.89, so a little bit, almost doubling of the risk. There's also, this is a Rotterdam study which looked at the association between subclinical hypothyroidism and cardiovascular disease. They looked at the effect on aortic atherosclerosis and on myocardial infarction. And as you can see, in patients with subclinical hypothyroidism, compared to the euthyroid patients, both these parameters of cardiovascular disease, both aortic sclerosis, aortic atherosclerosis and myocardial infarction, are much greater in incidence. And the incidence is even greater in patients who are antibody positive. So the highest risk is for patients with subclinical hypothyroidism and positive ATP antibodies. But subclinical hypothyroidism at any stage is associated with a greater risk of cardiovascular events. And the conclusion from this study is that subclinical hypothyroidism is related to increased risk of aortic atherosclerosis and myocardial infarction, especially when TPO antibodies are positive. And therefore, it is associated with an increased risk of coronary morbidity and mortality. There is also an association between subclinical hypothyroidism and heart failure. We're talking again about a hazard ratio of about 1.86. This emerged from a meta-analysis of around 6 prospective cohort studies, showing that as the TSH increases, the risk of heart failure increases. Hypothyroidism, even at the subclinical stage, is particularly worrisome in women. There's an association with infertility. So it is estimated that about 5% of infertile women are probably hypothyroid. There's an association with hypothyroidism generally can lead to, not talking specifically now of subclinical hypothyroidism, but this can be associated with menstrual irregularities and anovulation. Patients may have oligomenorrhea and irregular menses. There's an association with polycystic ovarian syndrome, a condition that is already associated with anovulation and infertility. Hypothyroidism of any degree is particularly hazardous during pregnancy. And in pregnancy, there's a greater risk for maternal gestational hypertension, anemia. Hypothyroidism affects with the overall growth and development of the baby. It leads to low birth weight and increases the risk of miscarriage. So having said that this is an extremely common condition, the symptoms could be very vague. Many patients may not know that they are hypothyroid. It is significant in terms of health impact, even at the subclinical stage. Should we be screening the population for hypothyroidism? And if the answer is yes, then how should we screen? Then to screen, there are 2 strategies. So either you screen everyone above a certain age where you think the risk of hypothyroidism is higher, or you screen patients who you think they have particular clinical risk factors for hypothyroidism. Now, the American Thyroid Association says about 60% of those with thyroid disease are unaware that they have the condition. And therefore, they recommended that you do a TSH on anyone above the age of 35. And if it is normal, repeat the test every 5 years. Many other authorities don't agree with this recommendation. They think there's probably no good hard evidence to support such a recommendation. It may not be cost effective. And they recommend screening only patients you think they are at risk of hypothyroidism. That is, anyone who has any of the symptoms that we discussed earlier, somebody with any lab abnormalities, those with anemia, hyperlipidemia, hyponatremia. If you do an X-ray and you find that someone has a pericardial effusion or pleural effusion, particularly in patients with any form of autoimmune diseases, patients with Turner syndrome or Down syndrome, any patient who had a previous thyroid injury or thyroid surgery, or they had irradiation to the neck, they recommend doing the TSH in the postpartum state. In someone who's on drugs that you think may interfere with thyroid function, or in those who have any form of a hypothalamic or pituitary disease. And the list goes on and on. You'll be surprised that there is no agreement on whether to screen pregnant women during the first trimester for hypothyroidism. And again, there's no recommendation to do mass screening of all pregnant women, but the recommendation is really to do a TSH and to screen for hypothyroidism in patients who are probably from an area in the world where there's a moderate or severe iodine deficiency, those who have symptoms of hypothyroidism, they have family history of thyroid disease. If they had ATPO antibody positivity at any stage of their life, all the type 1 diabetic patients, those who are morbidly obese, who have history of head and neck radiation, or those who have recurrent miscarriage. So again, in pregnancy, there doesn't seem to be a consensus or an agreement on doing sort of mass screening for hypothyroidism. Equally controversial, by the way, is the treatment of patients with subclinical hypothyroidism. Should we treat? And if yes, who should we treat? Should we treat everyone with subclinical hypothyroidism? And if not, then who is to be treated? Well, the treatment of subclinical hypothyroidism, now most of the guidelines, they do agree on one thing, that anyone with subclinical hypothyroidism and a TSH above 10 should be treated. The controversy is really in the category which is with a TSH less than 10. What do we do with these patients? So I put this table just to guide you on what to do in patients with subclinical hypothyroidism. Well, you need to ask yourself 3 questions. What is the TSH level? What is the age of the patient? And do they have symptoms or not? So what is the TSH? If the TSH is more than 10, right across the board, you start levothyroxine. Less than 10, patients are divided into 2 categories, those with a TSH just above the upper limit of normal up to 6.9, and then from 7 to 9.9. In this lower TSH category, you need to look at the patient's age. If they are more than 65, they are in the older age group, this TSH level may be appropriate for them, and just all you have to do is just follow them up. You don't need to treat them. However, if they are in the younger, relatively younger age group, less than 65 to 70, you need to ask yourself, are they symptomatic? Do they have convincing symptoms of hypothyroidism? If yes, you treat them. If no, you can still observe them. You don't have to treat them. Patients with a higher TSH, 7 to 9.9, again, are divided into 2 age categories. Above 65, are they symptomatic? You treat them. If they are not symptomatic, again, you can still observe them. However, the relatively younger age group, less than 65, with this level of TSH of 7 to 9.9, you should treat them. What do you treat with? You treat with levothyroxine. And when you're treating with levothyroxine, the objective really is to achieve 3 targets. You want to make the patient feel better. You want to alleviate their symptoms, their signs, their metabolic abnormalities. You want to get that TSH to the normal range without under-treatment or over-treatment. So what do the guidelines recommend? They recommend levothyroxine. This is the drug of choice in the treatment of hypothyroidism. Nothing else is recommended. And it's recommended because it's very efficacious. It has stood the test of time. It has a very favorable side effect profile, easily administered, good intestinal absorption, and has a long half-life and very low cost. Does it matter? Do you need to use a brand name of levothyroxine, or you can use anything? Well, the recommendation really to use brand name of levothyroxine. However, if you use a generic or any other preparation of levothyroxine, then please stick to it. Do not switch between different preparations of levothyroxine, because for the same dose of levothyroxine across the different preparations, bioavailability is very different, and you may not get to the TSH target with the varying preparations. This is just a study that looked at 2 preparations of levothyroxine and showed that for the same dose of levothyroxine, you have about more than 10% difference in bioavailability. And this variation in bioavailability will impact your TSH level, something you don't want to see in your patient. You don't want your patient, sort of shifting between a high TSH and a low TSH, both conditions being detrimental to the patient's health, especially the cardiovascular health and even their, nervous system health. A very important point is how should levothyroxine be administered in relation to food and beverages. And you'll be surprised how many patients are not told that levothyroxine has to be taken on empty stomach. And you need to leave at least an hour, preferably an hour, between the dose of levothyroxine and the first meal of the day or the first drink. I have many patients who come, they take their thyroxine with their coffee, and we know that beverages and food markedly interfere with the absorption of levothyroxine. Another thing that I'd like to point out is that you need to ask your patients if they are on any supplements that contain calcium and iron, because again, calcium and iron interfere markedly with levothyroxine preparation, absorption, and then these preparations have to be taken far away from the thyroxine medication. When you start your patients on levothyroxine, you need to monitor them closely. As I've mentioned, you need to avoid over-treatment and you need to avoid under-treatment because both of them are detrimental. So under-treatment, as we have mentioned, is associated with dyslipidemia that we discussed a little bit earlier and associated with heart failure and cardiovascular disease. Over-treatment is equally detrimental to patients' health, especially when you're dealing with elderly population, because over-treatment is associated with arrhythmias, especially atrial fibrillation, osteoporosis, and osteoporotic fractures. So you have to be very careful monitoring the TSH of your older age group patients. What do you do with the patient who is not adherent, patients who do not take their thyroxine? And you may come across these patients. Interestingly, because of the long half-life of levothyroxine, of 1 week, you can give the whole week dose in one go. So this whole 1 week dose can be given in a supervised manner on weekly basis. What if you keep increasing the dose of levothyroxine and you're not achieving the TSH target? The first thing, of course, you want to rule out is non-compliance. But if the patient is compliant, taking the medication regularly, and you think the patient is, you're really giving them quite high doses, and these high doses are quite inappropriate, then you need to think of factors within the gut interfering with the absorption of levothyroxine, like Helicobacter gastritis, atrophic gastritis, or celiac disease. You should screen your patients for Helicobacter and for celiac. You should correct these conditions. And once corrected, you need to make sure that you monitor the TSH so that you're not over-treating patients when they are over-absorbing. So, ladies and gentlemen, in summary, I have discussed with you briefly the prevalence, how we classify hypothyroidism, how do we diagnose it. I have touched mainly on the clinical consequences of subclinical hypothyroidism, the risk of progression to overt clinical hypothyroidism, the associated dyslipidemia, the risk with coronary heart disease, heart failure, and the impact the condition has in women's health, especially fertility and so on. I've discussed the dilemma of screening, and most of the guidelines now recommend some sort of aggressive case finding rather than mass screening. And I hope I was able to touch on some points in the management of hypothyroidism. I'm happy to take your questions.
Thank you so much, Dr. Ghaida, for the informative and interesting talk. We have a few questions coming from the audience. Let me start with the first question there. There's a question. It's saying many levothyroxine preparations are there in the market. Do you see any difference between different preparations or different brands? And do you have specific recommendations to the to a specific, not a brand name by itself, but what could be a good quality? What makes a brand as a good quality? Something like this, yeah.
Well, you want to choose a preparation that has a good, stable bioavailability over its shelf life. Levothyroxine is very prone to humidity, exposure to the climate. So you want really a very stable preparation. But as the guidelines recommend, if you use a preparation, please do not switch between preparations.
Okay.
Stick to the preparation that you are using.
Okay, and I think this is a continuation of the same question. It's saying, is there any difference between the brands that are in blisters and those in jars? Do you have any specific recommendation?
Blisters, you think that the tablet is definitely better protected from the elements, let's say from humidity and so on. So I would think that they would have better stability and more predictable, let's say, action. Compared if you're opening the jar and exposing it to the humidity and to the atmosphere, does that affect the bioavailability of the medication? Maybe yes.
Okay, very good. We have another question. When do we start thyroid supplement in a pregnant lady? Any range? It's again, the point of pregnancy, thyroid in pregnancy. What do you recommend?
Ideally, we should have some sort of population and also trimester-specific TSH ranges. If you don't have those, patients with elevated TSH above the upper limit of normal, let's say it is 4, especially if these patients are ATP or antibody positive, I want to treat them, and I want to aim in the first trimester of pregnancy to get the TSH to less than 2.5. And it's recommended that in the subsequent trimesters of pregnancy to have the TSH at least less than 3. So definitely ATP or positive patients with a TSH more than my target, I would really start them on treatment.
Okay.
I hope that answers the question.
Yes, hopefully. Another question is thyroxine dose for subclinical hypothyroidism the same as for overt hypothyroidism?
No. I think in overt hypothyroidism, in a young, healthy person, you may start at the full dose of 1.6 microgram per kg. In patients with subclinical hypothyroidism of the TSH, depending on the TSH level, I usually like to start with the smaller doses, 50 microgram, for example, repeat the TSH in about 6 weeks, and then gradually increase the levothyroxine dose to get the TSH to the target. So I don't usually in subclinical hypothyroidism start with the full dose that we use in overt hypothyroidism.
Okay. I think another question is when to check TSH after change of dose.
Anytime you make changes to the dose of thyroxine, ideally, you should check the TSH in about 4 to 6 weeks, around 6 weeks, because remember this drug has a long half-life, and to get it to a stable level,
Yes.
you need around 6 weeks. So I usually call the patient in 6 weeks anytime I make changes to the dose. Now, once we've achieved the TSH target, then you can see your patient, and you know that this is the dose that the patient requires. You can see them every 6 months.
Okay, great. Another question, again, related to pregnancy. It's saying, what is the appropriate TSH range for pregnancy? Yani, is there a specific target when treating pregnant ladies different from the normal hypothyroid patient?
Yes, as I've just mentioned, ideally the TSH level should be less than 2.5 during the first trimester of pregnancy, and less than 3 during the second and third, 3.5 during the 3.5 during the second and third trimester of pregnancy.
Okay.
So less than 2.5 in the first trimester, less than 3.5 in the second and third trimester.
Okay.
This is the TSH target, yeah.
Yes, yes. Here's a question. It's a big question. I'm just trying to. It's some sort of relation between hypothyroidism and dyslipidemia. Otherwise, I'm very conscious about my diet and how do I control my cholesterol. It's the relation between thyroid and dyslipidemia, I think. So,
okay, so as I've mentioned in the presentation, there's a definite association between hypothyroidism and dyslipidemia. And the two lipid parameters that are affected by hypothyroidism is LDL cholesterol and triglyceride-rich particles, especially the remnant triglyceride-rich particles like chylomicron remnants and intermediate density lipoproteins. And we know that intermediate density lipoprotein has atherogenic properties. So yes, there's an association definitely with LDL and with the triglycerides. But as I've mentioned in the presentation, this dyslipidemia is reversible with treatment. So when I see a patient with hypothyroidism and I've done their lipid profile and I see that they have high LDL, I honestly do not start them on a statin straight away. I correct their thyroid status, repeat their LDL cholesterol or lipid profile subsequently before deciding on whether they need a statin. And you'll be surprised, most of the patients really correct their lipid profile with the treatment.
Excellent. Okay, here's a question is about taking a total weekly dose once. Will it cause symptoms of hyperthyroidism?
No. Okay. It doesn't cause symptoms of hyperthyroidism.
So is it possible to take the whole dose for the week once?
Once, yes, you can. Yes, it can be given once. So, and this is really, I mean, we don't often do this kind of, but sometimes in difficult situations, I've had patients who will refuse to take their thyroxine, or they have some sort of mental, their mental capacity is not really at its best, and they don't take the medications. So it's ideally the weekly dose should be supervised by a family member, an adult, for example, who gives them the medication under supervision in one go.
Okay.
And it doesn't cause hypothyroidism. Yeah.
Yes. Okay, there's a question here. It's two-part. One part is again about taking the dose once, but it's already answered. It's about recommendation for levothyroxine in Ramadan. Do you have any specific recommendations during Ramadan?
Yeah, Ramadan is really a big issue because it's very difficult to tell the patients, because ideally you should wait for an hour. Now, I tell my patients, if you can't wait for an hour, minimum you need to wait half an hour. But even that half an hour may not be very easy during Ramadan, honestly. I mean, to take the tablet, wait for half an hour, 1 hour before iftar is a bit difficult. So what you can do is that tell the patient you can take it later in the evening, but please keep at least 3 hours after the meal. They can take it before, so if they have their dinner, for example, at, 10 or 11, and then they wake up for suhoor and they can, take the medication then, as long as at least 3 hours have passed since the last meal, that should be okay. So keep 3 hours between the meal and taking the medication. You can take it before suhoor, you can take it at night, having left 3 hours at least after the meal.
Okay. Okay. Another question here, which I believe it was covered. It's again asking about the appropriate age for screening.
Well, I mean, if you follow the ATA guidelines, they want to screen everybody 35 years and above. But I think most of the recommendations is really to screen anybody who has any suggestion that, you feel that they may have hypothyroidism, they have signs or symptoms, or they are at risk population because of the several factors that we have discussed. So there isn't an age. For population-based screening, yeah. I mean, as I said, there is no recommendation now for mass screening of the entire population. There's no agreement, let's say, on that kind of approach.
Okay. One more question here is about the up titration. Yani, how do you do the up titration for newly diagnosed patients? Do you usually do it on weekly basis or based on your expertise?
No. I mean, the dose has to be up titrated every 6 weeks. You can make increases by about, depending on the TSH level, honestly. First of all, in overt hypothyroidism, as I said, in young, healthy people, you can give them the full dose in one go. Just calculate 1.6 microgram per kg body weight. You have to be very careful in all the age group, people with cardiovascular disease. In these patients, you have to be careful. You have to start with low doses, like 50 micrograms or even sometimes 25 micrograms, and you have to go really slow and make the increments also very low increments and slowly. Increments, once you've calculated the dose, repeat the TSH after 6 weeks, and in 6 weeks you're not at target, you increase the dose. You make an increment by, depending on the TSH where you are, by 25 microgram per day, say, on the average. And every time you make change, repeat the TSH again after 6 weeks.
Very good. Very good. Another question here is about the antibodies. Do we need to do the antibody test for each case of hypothyroidism or for specific cases?
I mean, honestly, I would do it in anyone who is hypothyroid, because I would like to do the ATPO antibody. I do them once. I don't keep monitoring the antibodies. Once it helps in establishing the diagnosis as Hashimoto's. And all you need to do is really the ATPO antibody. I would do it once in anyone with hypothyroidism, but I don't keep monitoring the levels. I see people, having ATPO antibodies being measured every now and then. I don't see the point in doing that.
Okay. Another question here is, can we do the thyroid function test while fasting? Or any?
Yes. There's no harm. Absolutely.
Okay.
I don't specifically ask my patient to come fasting, because I do it, it becomes a little bit inconvenient if you have to call the patient specifically to come to the center fasting to do. So when they are here, I usually request the test. I don't ask them specifically to come fasting, but doing it fasting is fine.
Okay. I think we have a couple of more questions here. One question is referring to the case of Rania, which we had the campaign or episodes revolving around, communicated to our doctors. It's saying here, how do you deal emotionally and psychologically with the very irritated hypothyroid patients when they first visit you in the clinic?
I think from my point of view, honestly, I mean, you need to be compassionate. You explain to the patient their condition. As a matter of fact, you'll be surprised. Many of the patients, they feel so relieved once they know that there is a cause for this, whatever they are going through. When, I mean, if the patient is very irritated and you tell them, this is because of your thyroid and we have a treatment for that, they'll be relieved. So I think my role as a physician is to give them their thyroxine and reassure them that all these manifestations of hypothyroidism will be reversible with thyroid treatment. And they do get better. They feel better. Honestly, on the first visit after starting them on treatment, they come and tell you they're already feeling much better. So I don't think you need to consult any psychiatric help, let's say, but these symptoms are also reversible unless there's something else. Yeah.
Yes. Here's a
Other than the
question.
thyroid.
Yeah. We have a question. It's, I'm not sure I quite understand. It's saying medications stopped with normal blood reports. After that, body weight is increasing. What to do? Yeah.
Every overweight and obese patient who comes to the clinic, they're coming here with the hope, that they are hypothyroid. They hope they are hypothyroid so that you can treat their thyroid and the weight goes back to normal. I mean, most of the time, honestly, overweight and obesity is not related to hypothyroidism. Okay. So if the obesity most of the time is related to the lifestyle of the patient rather than the thyroid function. So I do the TSH in every obese patient just to make sure that hypothyroidism is not a contributor. Once thyroid is out of the way, then you really need to address their lifestyle, especially their eating habits.
Yes, exactly. And continuation of the question here, they're asking usually how long does it take after the treatment so that the patient will these symptoms will disappear? At least 70 to 80% of these symptoms disappear. Usually it takes how long? Starting from day one from the treatment?
What symptoms, sorry?
I mean, in terms of patients who are obese or having like hair loss or other symptoms, depression, usually these symptoms, they start to disappear like after how long, like 1 month of treatment, 2 months or 3 months, usually, from your practice and experience?
I really cannot give you a timeline, honestly. I mean, especially the weight issue, it's not that once you correct their thyroid, in a month or 2 months, they're going to lose all the extra weight. But you put them on the right track. You correct their hypothyroidism. You inform them about the contribution of hypothyroidism to their obesity and advise them on the right lifestyle. But what timelines it takes for these for the weight to go down, it takes. Patients have to be really patient, I mean, they're not going to become slim in a few months' time. No, it's going to take time.
Yes.
Yeah.
Okay. One more question here is some patients, their daily dose not the same every day. For example, for 5 days they take 75 microgram, and in the weekends they take 100 microgram. Is this acceptable and appropriate?
It's acceptable, but I would try to make the dosage regimen for the patient as simple as possible. So I have patients who are doing this, and what you can do is you can calculate the total weekly dose and divide it equally across the 7 days, just to make it simpler for the patient, because it can get a little bit confusing that on this particular day I have to take this dose and on another day I have to take a different dose. If you can make it as simple as possible, yes, please go ahead. But yes, it's acceptable. There's no harm in taking different doses on different days, as long as you are at your TSH target.
Okay.
But ideally, make it as simple as possible. Make it consistent so that they're taking the same dose every day, if achievable.
Okay. Just one question here. It's about what are the risks or maybe side effects of levothyroxine? Any side effects that you have encountered with some of your patients?
Honestly, I haven't had side effects of levothyroxine. In clinical studies, headache is reported. I haven't seen, I've seen some patients even with the smallest dose getting a little bit of palpitation. So sometimes I'm conscious on starting some patients who are very anxious on starting them on the full dose. I don't. So usually I back off a little bit on the dose and I go slower if I think the patient is an anxious type, because I had patients even with a 25 microgram coming telling me they am having horrible palpitation. Yes. Generally, this is not very common, but it can happen. I mean, you come across the patients who react differently to medications. Other than that, I mean, if you're not over-treating the patient, you shouldn't see side effects. Over-treatment, when you are making them iatrogenically thyrotoxic, yes, they're going to have symptoms, of course.
Yes.
Yeah.
Yes, I agree. Okay, question here is, can the medication be stopped if there are persistent normal range of TSH?
Um, sometimes, honestly, immune thyroiditis behaves the way it likes to behave. I've seen patients with immune thyroiditis who after some time, the great majority of these patients, they are hypothyroid forever and they require treatment for good. There are some occasionally patients who fluctuate between hypothyroidism and hyperthyroidism and euthyroidism. And I have seen patients who had Hashimoto's and they've been on treatment for a long, long time. They stop the medication on their own and they come to me with a normal TSH. So I just monitor them and tell them you need to keep an eye on your thyroid functions because anytime the thyroid go out of range, we need to restart the treatment. Yes, it happens. It's reported. I've seen patients who fluctuate between hypothyroidism and even frank thyrotoxicosis.
Yes, yes. Okay, we have one question also here about, do you think that some patients need T3? I mean, there are some preparations that provide T3. So is there any role for T3 in treating hypothyroidism?
Not really, honestly, no. And even the guidelines do not recommend T3 treatment. I mean, I've had a couple of patients who are so convinced that they feel better with the addition of small doses of T3. They're happy with it. I lead them on it. There are a lot of studies relating to the deiodinase activity of certain individuals, that these patients are not, having enough T3 in their system. But this is all in the research realm, let's say. But in clinical practice, rarely ever you need to give. I've done that in some post-thyroidectomy patient for thyroid cancer who continuously had all sorts of symptoms. And whatever you do to their thyroid management, they come to you with all sorts of, very non-specific symptoms that you cannot really pinpoint. Sometimes I tried adding T3, but after some time I convinced them, that it's really not needed, and we took them off, and finally they settled down. So in the great majority of patients, no need for T3.
Yeah, yeah. We have like final two questions here. One question is about any relation between diabetes and thyroid. I mean, people with diabetes, are they, probability of having thyroid problems, is it higher than the normal people?
Absolutely. This is true. Especially type 1 patients, you need to screen them for hypothyroidism. And even type 2 patients, I do a TSH on them annually, because definitely there's an association between diabetes and hypothyroidism, more so in the type 1, but also in type 2. So diabetic patients should be screened among those patients who should be screened for hypothyroidism.
And here, doctor, you're referring mainly to diabetes, the type 1, or is it for both type 1 and type 2?
I do a TSH annually on patients with type 2 as well.
Okay, yeah. Great. We have here one last question. It's again related to pregnancy. The doctor is asking, for healthy pregnant patient with TSH about 4 to 5, does this need treatment?
Are they ATPO positive? If they are ATPO positive, I will do their antibodies. ATPO positive, I would treat them definitely. Honestly, a TSH of 5 in pregnancy, if it's consistently in that range, I'm not very comfortable also. So sometimes I do give small doses of thyroxine, especially in those patients who are ATPO positive.
Yes. Okay, so I think we do not have any more questions. I'm just checking here in the Q&A inbox. So I think we are fine. we can conclude. Yani, thank you so much, Dr. Ghaida, for this presentation and for the Q&A session. I believe you've covered a lot, and it's really interesting. We've went through really how to screen and how, and even emotionally, how we communicate with the patient emotionally when the patient is frustrated about the symptoms, and the recent guidelines till choosing the right treatment and having a precise dose recommendation. So thank you so much for the presentation, and we hope to see you in other events soon with us. And I hope that the audience has enjoyed this presentation. So thank you so much. Thank you very much for the presentation.
Thank you, Mohammed. Thank you, everybody. Thank you.
Thank you, Dr. Ghaida. Thank you.
Thank you. Bye-bye.
Thank you. Goodbye.